we'll do is we'll make a start then. I'll just do a bit of an introduction for everybody. Thanks everybody for coming along. Welcome to this Ovarian Cancer Action webinar on risk reducing gynae surgery. My name is Jo and I'm the Cancer Prevention Officer at Ovarian Cancer Action. This webinar is one of a series of workshops and webinars as part of the joint Staying Connected project between Ovarian Cancer Action and Overcome. There are lots more sessions coming up, so please take a look at the programme on our website. We're currently booking in loads of new sessions, particularly for the end of September and beginning of October. So take a look. There's lots of different topics on there that you might be interested in. We've also recently set up a monthly newsletter specifically for people with high genetic risk. That's got lots of updates on things like our webinars, updates on COVID info and screening and so on, research and guidelines, things like that. So please do sign up for anything if you're interested in that and keeping up to date. A little bit of information first on the session. So in today's webinar, you should be able to see both myself and our lovely guest. We'll be recording this session so that we can share it with you and anyone else who might find it useful. So please don't feel like you need to take any notes, as you'll be able to watch it back once we post it up to our website. You'll see along the bottom of your screen there should be some buttons. You can ask questions as we go along using the Q&A function, and we will keep those anonymous. I won't read out any names, but I'll read them out as we go along. And I've also got a big list of questions that people have sent in advance as well that we'll go through. We will try and get as many of these questions answered as possible today, but this has been a really, really popular session with lots of questions in advance already sent in. So I do apologise in advance if we don't manage to cover every single one. If you do have a burning question that we miss, please do get in touch. My email, you can reply to the emails with the sign up instructions, or it's braca@ovarian.org.uk, and I'll do my best to get it answered for you. Do want to have a bit of a caveat at the beginning. This isn't a medical consultation, so please always do take your personal questions to your medical team. So to introduce our guest expert today, Dr Adam Rosenthal is Consultant Gynaecologist and Lead Colposcopist at UCLH. He's also the clinical lead on the UK Familial Ovarian Cancer Screening Study that you may have heard of, and also Medical Director of the ALDO project, which is something really, really interesting. So thank you so much for joining us today, Adam. Could you tell us a little bit about your role, just to kick off?
Yeah, and I think for the purposes of this audience, and thank you very much those of you that have tuned in today, I've been interested in familial gynecological cancer and cancer prevention well over 20 years now, and I run the Familial Cancer Clinic at University College Hospital in London. We do an awful lot of risk reducing surgery, probably over 50 to 70 bilateral salpingo-oophorectomies a year, usually for BRCA carriers, and probably over 20 total laparoscopic hysterectomies and bilateral salpingo-oophorectomies for women with Lynch syndrome. So we've got a lot of experience at UCLH of dealing with specifically women at increased risk of gynecological cancer because of inherited predispositions. We're plugged into various other services like menopause services, for example, and clinical psychology, which can often be very useful when women are finding these really tough decisions, particularly difficult to get to grips with. And clinical psychologists can be very useful at helping women focus on what it is that's really making them decide or not decide to have the surgery, and sort of seeing their way through what can be quite a challenging path at various points. So yeah, it's a real passion of mine. I've been involved in it for over 20 years, and I'm always delighted to have the opportunity to answer questions. I wish this was a face-to-face thing. In the old days, we'd have been doing this in a meeting room somewhere, but hopefully you can still get some benefit from listening to what we're going to chat about today.
Absolutely, thank you so much. We've had lots of questions, as I said, sent in already about options for both BRCA and Lynch carriers. So I wonder if you could start off by just giving a really rough overview of what the guidelines are, maybe starting off with BRCA to start with regards to risk reducing surgery.
Yeah, I mean, I think the first thing to say about for BRCA carriers is that really it is something that at some point in your life you really need to be doing. The evidence is quite clear that it reduces your chance of dying from an ovarian cancer if you have the surgery. Sadly, if you're a BRCA1 carrier, your risk may be of the order of 1 in 2 in your lifetime, and for BRCA2 maybe of the order of 1 in 4 ballpark figures. So these are really extremely high risks, and unfortunately As many of you are aware, ovarian cancer can be very difficult to treat successfully. It's really not a pleasant disease to get, and anything you can do to prevent that is the right thing. But the only thing that's proven to work beyond doubt is removal of the tubes and ovaries. Now, that's not such a big decision if you're postmenopausal, perhaps, but if you're premenopausal, you maybe haven't completed your family, or you are not willing to take hormone replacement therapy for whatever reason. Possibly you're medically not allowed to because you've had a hormone-sensitive breast cancer in the past, then it's a big decision to have your tubes and ovaries removed before the age of 51 or so, which is the average age of menopause. So the general guidance at the moment is for BRCA1 carrier, we would recommend you consider having the surgery after the age of 35, and for BRCA2 carrier after the age of 40. We would modify those years down a bit, those ages down a bit, if there'd been a particularly early onset ovarian cancer in your family. Not early onset breast cancers. I'm glad to say the age of the breast cancers in your family has no impact on the age at which someone in your family might get an ovarian cancer. But if, for example, you are a BRCA1 carrier and you have an aunt who had ovarian cancer, say at the age of 39, which would be very unusual, but does occasionally happen in BRCA1 carriers, then we would actually be willing to offer you the surgery from 5 years before that age, so from the age of 34 onwards. Just on the principle, it's a common sense principle that if there's one early onset, really early onset ovarian cancer in your family, maybe there's something different about your family in particular. Either you've got a shared environmental background to the woman in your family who got ovarian cancer early, or maybe you've got other genetic factors other than just your BRCA mutation that are making that BRCA mutation cause cancers of the ovary at a really early age. We don't know. It's a common sense decision, but it does mean that for women with that kind of a family history, our advice may be a little more, you need to be going through surgery now, rather than, oh, you know, your chances of getting cancer in the next year or two is so low, it would be absolutely fine for you to delay the surgery by another year or two. You'd be taking a very low risk if you did that. That advice might be different. So that's why it's so important to get details about your family history, the ages at which the women got cancer, if possible, and certainly death certificate proof of that particular diagnosis. The cancer genetics teams are primed to help you get that information, but you can go onto the government website and pay about, I think it's £11 or so for a copy of a death certificate on your relative, which at least gets the ball rolling in terms of proving the diagnosis, even if the age isn't necessarily the age at which they got the cancer. And I should point that out, it's the age at which they get the cancer rather than the age of death if they're unfortunate enough to have died from their cancer.
I think you've covered answers to several of the questions that I have on my list just in that one answer, so that was very
great.
I wonder if you could do kind of a similar thing for women with Lynch syndrome. Are there any differences there with what women with Lynch syndrome
definitely there are differences, and it's very much dependent on which mutation you've got, as it is in BRCA, as I've already indicated, that we give different advice according to which BRCA mutation you've got. The same would be true for Lynch syndrome. And to be quite honest, there are too many different mutations for me to carry around in my head those particular age cutoffs. So what I do is I use the sensible version of Dr. Google, which is something called a prospective Lynch syndrome database. What I'm going to do now is I'm going to share the screen with you. Now I should a disclaimer here, okay, this should only be utilised in conjunction with a healthcare professional who's up to date in this field. And even I, as someone who's been doing this for over 20 years, although not with the benefit of this website for that long, would still defer to my clinical genetics colleagues for specific advice. But as a general guide to what you can be looking at, I think that this is a useful tool. So I'm going to do the share screen now, and let's see if this works. Share my entire screen, yep. I've got a feeling, Joe, do you have to let me do this? Or am I?
You should be able to do it as a panelist.
Okay, here we go. Let's try this. Yes, I am. Great. Well, I will now take you to this website here.
Brilliant.
If you look at this, this is the URL. And if that doesn't work for you, just Google prospective Lynch syndrome database.
And I can send a link through to everybody.
Yeah,
Joe can send, so don't worry about,
So this is an interactive tool, And what you get to do is you get to choose which cancer site you are interested in looking at, what the genetic variant is that you have a mutation in, and what your current age is. It does it in 5-year age gaps. So let's say you are a 35-year-old MLH1 gene carrier. Let's look at the risk of endometrial cancer in that situation. So here we are, you're starting off at 35. This is the rate at which the risk increases over time. So you've got age on the horizontal axis and percentage risk of cancer by that age. So this is what it looks like graphically, but you can do it a bit more easily by looking at it in these 10-year age groups. So between the ages of 35 and 40, you've got about a 2%. So that's a 1 in 50 chance of getting cancer in the next 5 years. But if you left it to the age of 50 before you had your hysterectomy and removal of the tubes and ovaries, you would have about a 15%. So that's about a 1 in 7, 1 in 8 chance of getting a cancer of the womb by the age of 50. So you might think, I would quite like to avoid that risk, and I'm going to go for the surgery sometime between the ages of 40 and 50. And then if you look at the risk for ovarian cancer, luckily it's considerably lower with this particular mutation. And the risk by 50 is only about 5 or 6%. So that's about 1 in 20 or so, isn't it, give or take. Whereas if we contrast this with, say, MSH6, the ovarian risk is low, but if you look at the endometrial cancer risk, that is you know, a little bit lower than it was with MSH1, but you can see that it does change a bit. And one of the key points is, for example, if you are a PMS2 carrier, and that's one of the much rarer Lynch syndrome mutations, that is not currently thought to confer a very high risk of ovarian cancer. In fact, it may not increase the risk at all. So that's the situation where the genetics team would have to look very carefully at your family history, which mutation you've got. And it might be that you're considered not to be at increased risk of ovarian cancer, but you are still at increased risk of womb cancer. So I guess what I'm saying in a nutshell is that it's a little bit more complicated advising people about the correct age for having the surgery in Lynch syndrome. But as a rule in thumb, we would say consider the surgery from the age of 40, because pretty much all of the mutations would begin to increase the risk of womb cancer from the age of 40 onwards. And again, there would be that similar caveat that I mentioned with BRCA carriers, which is that if the risk is if in your family you've got a particularly early onset womb or ovarian cancer, then we might bring forward the age at which we offer the surgery. I'm going to stop sharing the screen now, and we'll just go back to my ugly mug here. But basically, there is one other caveat to that, to those rules of thumb, and that is that particularly for BRCA carriers, many women that have had chemotherapy are unfortunately rendered postmenopausal prematurely as a result of that. That wouldn't typically happen in younger women receiving breast cancer chemo, say in their 30s. And particularly now, oncologists are giving injections to temporarily stop periods during chemotherapy in the hope that this will help preserve the ovarian function so that periods can return after the completion of chemo. And that actually has quite a lot of success. So it's by no means inevitable that people that have had breast cancer chemo become prematurely menopausal. But for those women in whom it appears to have happened, and there are still quite a lot of them, then clearly there is very little advantage to them holding onto their ovaries if they're no longer functional, despite the fact that they're under the age of 40 perhaps. So in that situation, we would say you don't have to wait until you're 40 to have your tubes and ovaries removed, because unfortunately your ovaries have already stopped working. It looks like at this point they're very unlikely to start working again. So why not get the surgery over and done with now if you want to do that? And obviously it's your choice, because the risk of cancer is not at all high when you're under the age of 40. Unless there's someone in your family with a very early onset ovarian cancer, which most BRCA families and Lynch families won't have.
That makes a lot of sense. Thank you. And that's really, really useful to see those figures. I think a question that we have quite often is understanding from what you're saying about when the risk increases for various different mutations. A question that comes up quite often is, well, if I finish my family and I'm 30, why can't I just have the surgery straight away? Why should I wait for the risk to start going up? I wonder if you can talk a little bit about that.
Yeah, I mean, I think that, I mean, that's a very obvious question that people would ask. And the answer is, we can't predict how you're going to feel on hormone replacement therapy. Everyone who's not had a hormone-sensitive breast cancer would be considered a candidate for hormone replacement therapy if they have their premature menopause as a result of having the ovaries removed. And even patients with triple-negative breast cancer, some of them, their oncologists are willing for them to have hormone replacement therapy once they've had their tubes and ovaries removed. We can't predict how you're going to feel on that. Some women will feel the same as they do premenopausally. Some will feel better. For example, if you've had very bad premenstrual syndrome, PMS, and that's classically associated with the hormonal fluctuations that women with their own natural cycles have. Sometimes if they are on a very steady level of hormone by taking HRT, excuse me while I just get a sip of water, then they may actually find that their PMS is improved, although that's not guaranteed. And then there's a minority of women who actually feel worse on hormone replacement therapy. And of course, there are many different types of HRT in terms of exactly which drug you take at exactly which dose and how you take it, be it patches or tablets or gels, for example. And you can chop and change HRTs a lot to see if it makes a difference. And you can add in testosterone if someone's lacking a bit in sex drive or lacking in energy levels. That can help some women. But you have to go into this surgery with open eyes, and you have to understand that there is a possibility that no matter what kind of HRT we give you, you won't feel the same as you did before. For some women, that's a blessing because they feel better. But for others, it's not a blessing, and they may regret their decision. Although most women, the studies would tell us at least, will say, yes, they are happy to put up with these side effects because they are so happy not to have the risk of ovarian cancer hanging over them. And this is an incredibly individual choice and an incredibly individual experience. And all you can do is, I think, take hope from the fact that the majority of women will say to you afterwards they're glad they did the surgery, even when they have some issues with the HRT. It's probably worth also mentioning why HRT is so important, because you might say, well, if I'm not happy with side effects, but I really want the surgery because I'm really worried about ovarian cancer, why should I bother with HRT at all? Well, the answer is two things really. One is that it appears to be safe from the cancer risk perspective afterwards. There's a lot of mythology about the massively increased risk of breast cancer with HRT. This really primarily applies to women in the general population without mutations who take HRT beyond the age of natural menopause. And that, if you think about it, is an unnatural state of affairs. And what you're doing there is you're exposing your breast tissue to levels of hormone for far more years than would have happened in the natural world had you gone through a normal menopause. That's one issue. The other issue is that when we give you HRT and you've had a premature menopause because of having your tubes and ovaries removed, what we're doing is giving you back hormones you would have had naturally anyway had you still got your ovaries, and in fact we're giving them back at a lower dose than your ovaries are making normally, and we're not suggesting at the moment that you carry on taking it beyond the age of 51, which is the average age of menopause. There are lots of studies, or not lots, sorry, there are a few studies looking at the safety of HRT in BRCA carriers if they take it up to the age of menopause only, and there is slight conflicting evidence in those studies, but there is certainly no strong evidence saying that it is dangerous to take HRT if you're a BRCA carrier, because primarily your main risk of breast cancer if you're a BRCA carrier is from the mutation. It's not from taking HRT from the ages of when you have your surgery to the age of of 51 or so. So that's the first issue with taking HRT. It doesn't seem to have a really negative impact on your breast cancer risk. And obviously, if you're considering risk-reducing mastectomies, then it's even less important, because by the time you've had the risk-reducing mastectomies, you will have such little amounts of breast tissue left inside you that whether you take HRT or not is really neither here nor there. The main reason, though, that we really want you to take HRT is that there are proven long-term detrimental effects to your health if you do not take HRT up to the age of 51 or so. And these are actually life-changing impacts on your health. These are osteoporosis, so that's brittle bones, which means you're more prone to hip fractures and spinal fractures at young ages. And if you get either of those, that's life-changing and in some ways even life-threatening, because if you get a hip fracture and become immobile, it does actually increase your risk of death. So that's one negative impact if you don't take HRT. Another issue would be that you increase your risk of cardiovascular disease. So women are protected compared to men by their hormones in terms of getting heart attacks and strokes, and that's why younger men are at higher risk of heart attacks and strokes than women are. But when women become postmenopausal, that's when their risk of cardiovascular disease begins to increase and begins to get closer to the pattern seen in men. And obviously you can do things to reduce that risk, like maintaining a healthy weight, not smoking, having a good diet, and getting your GP to check your cholesterol and blood pressure once a year once you're over the age of 40. But ultimately, if you don't take HRT, your risk rapidly approaches that of a man's. So we want you to avoid heart attacks and strokes by taking your HRT up until the age of 51. There was a lot of bad press about HRT increasing the risk of strokes when the Women's Health Initiative study came out in America. This was a very skewed study in terms of what advice we should be giving BRCA carriers, because this was a study looking at HRT in postmenopausal women, so women who are all over 50, and in fact, many of these women were actually over 60 or at even older ages and didn't start their HRT until that age. Now that's an extremely unnatural situation, and there's nothing whatsoever to do with BRCA carriers taking HRT as true replacement therapy for hormones that they've lost, say at the age of 40, if that's when they had their risk-reducing surgery done. So you cannot extrapolate risks from the Women's Health Initiative study looking at really substantially older women taking HRT in a really quite what we would consider fairly unnatural way when they've already gone through a natural menopause. I won't bore you with the theories as to why that might and probably does increase the risk of stroke and possibly heart attack, but that is not the same situation as a BRCA carrier. So BRCA carriers should not be worried about taking HRT. Sorry, my screen's just gone blank. You can see me still.
Good. See you, that's fine, yeah.
Right. So I didn't toggle my mouse for a couple of minutes. It gets anxious and turns me off. Okay, so hopefully that's dealt with those issues for you, Jo, and whoever's listening.
That's really, really helpful summary there. One of the questions that comes up an awful lot, which I think I've actually asked you about before, but for everybody here, there's always a lot of questions about whether BRCA carriers should be having a full hysterectomy or just the ovaries and tubes removed. So could you explain a little bit about the advice on that side?
Yeah, so I think a lot of this is just sort of historic. It's just what people did. And there are certainly, or at least there were some centres in the UK still doing this quite a lot. In America, it's all done still quite a lot. I'm going to be a bit contentious here and point out that in America, it tends to be fee for service. So the surgeons get paid more if they do a bigger operation. I'm not going to say that's the case for all gynecologists in the US. I know many US gynecologists who practice what we do at most places in the UK. And that what we practice for most places in the UK now for BRCA carriers is that we only remove the tubes and ovaries. And there are a variety of reasons for this. The first main reason is that it's a smaller, quicker, easier, safer operation, which you are more likely to recover from quickly with a lower risk of a significant complication. And with cancer prevention surgery, I think this is absolutely paramount. We are not talking about a situation where a patient already has cancer and anything we can do to make them better is therefore incredibly important. What we're talking about here is taking a fit, healthy person who's often very young and in the prime of their life, and what we're trying to do is get rid of a risk of a potentially fatal cancer, but by doing the minimum amount of damage to that person. And I'm talking about a combination of physical damage in the short, medium and long term, and psychological damage in the immediate, medium and long term as well. And the way to minimize those risks is to do the smallest operation possible that gets rid of the risk of cancer. And in the case of a BRCA carrier, that would be taking away their tubes and their ovaries only. And people will come up with various reasons as to why they suggest it would be a good idea to remove the womb as well. Now, one reason is women will say, well, we've been taking tamoxifen as breast cancer treatment or as breast cancer prevention, and we know that tamoxifen increases the risk of womb cancer, so shouldn't we be having our womb removed as well? Well, the simple answer is yes, it does increase the risk of womb cancer a little bit. Those womb cancers are rarely fatal because they tend to be ones that declare themselves fairly early, when they're early stage with abnormal bleeding. Plus, people know they're on tamoxifen, so they know to report abnormal bleeding sooner rather than later. The doctors know they're on tamoxifen, so they know to investigate the women sooner. So those cancers tend to get picked up at early stages where they're curable by hysterectomy anyway. Plus, the risk is not that high. So we would have to do about 50 hysterectomies in BRCA carriers on tamoxifen to prevent one patient from getting cancer of the womb lining. Now, not all of those women are going to get complications if we do hysterectomies, obviously, unless we're really hopeless surgeons. You know, the vast majority of them would not get a significant complication. But by the time we're doing 50 hysterectomies, one or two of them are going to start getting some level of complication, be it a prolonged hospital admission because of a pelvic infection, or possibly an infection, or a deep vein thrombosis. I mean, these are not common events, although the kind of post-operative infection thing with a hysterectomy can be relatively common. Perhaps 1 in 10 women will get it despite your best efforts. So what you're doing now is you're beginning to increase the morbidity and the risks to the patient by doing a bigger operation than was strictly necessary for preventing one cancer in 50 women that would likely have been curable with the same operation in the first place. So you can see how the sums just don't seem to add up there particularly well. The other argument people will come up with is, well, we've heard that BRCA carriers have an increased risk of womb cancer that's nothing to do with them taking tamoxifen. And it is true that BRCA1 carriers appear to have a slightly higher risk of a very rare type of womb cancer called high-grade serous endometrial cancer. Now, that kind of cancer, the risk does seem to be increased, but it's so rare that the number of women who get it is actually pretty small, even if you're a BRCA carrier. BRCA1, in fact, BRCA2 doesn't seem to be associated with that increased risk. So again, the ballpark figures you're looking at is maybe 1 in 50, maybe at absolute worst 1 in 35 or so. Women might get a womb cancer if you didn't do a hysterectomy. Now, it is true to say that this particular womb cancer is a bit nastier than the very curable ones that we tend to see with tamoxifen. And so for that reason, it's been the policy, at least within our unit and the unit at Barts, and we work jointly as what's called the London Cancer Network Familial Cancer Clinic. And our advice would be that if you've got a proven diagnosis of high-grade serous endometrial cancer in your family, then yes, we would be willing to offer you a hysterectomy, because maybe there's something about your family, as we discussed with the age of onset of ovarian cancers, for example, in BRCA carriers. Maybe there's something about your family in terms of your shared other genetic or environmental factors that means your particular family is more prone to get high-grade serous endometrial cancer, which is this very rare endometrial cancer that may be slightly more common in BRCA1 carriers. And the final reason, and this is another reason why, yes, it might be sensible to have your womb removed, is if you've got another very good reason for having a hysterectomy, like you've got massive fibroids, or you've got a lot of prolapse where the prolapse surgeons have said, you know what, you're better off having your womb removed because it's not going to be easy to support it by other means. Although now, as it happens, there are some quite fancy ways of supporting a prolapsed womb with just laparoscopic surgery rather than a full hysterectomy. You know, every case is different, and we take every case on its own merits, and we do take the wishes of the women into account. But at the same time, we have to do what we feel, or rather we have to offer what we feel is in your best interests. And we're not going to routinely offer surgery to remove the womb for a BRCA carrier. Now, for Lynch syndrome, of course, it's completely different, because women with Lynch syndrome, their predominant gynecological risk is from womb cancer, not from ovarian cancer, although many of the mutations do cause a risk of ovarian cancer that's high enough that we would recommend having your ovaries removed at the same time. So yeah, I think that probably just about covers all of the issues that I can remember off the top of my head that are related to offering hysterectomy or not to women increased risk. And it is very different for BRCA carriers to Lynch syndrome carriers.
Absolutely, thank you very much. We had a question about whether research shows that just removing fallopian tubes is effective against reducing the risk of ovarian cancer, and whether you think this will be an option for everyone in the future.
My gut feeling is it will be an option for everyone in the future. Where we are with it now is that my friend Ranjit Manchanda, who's a colleague of mine at Barts, who is also very interested in this field, has been running what is now a national study that both Barts and UCLH and many other cancer centres around the UK are also recruiting patients to. Incidentally, it's been on temporary hold during the pandemic, but it looks like it's going to be back up and running again very soon. This trial is called Protector. I'll see if I can find that website for you in a minute, or Jo can perhaps be queuing it up while I talk, and then maybe she can share the screen because I'm going to keep talking and she can be looking while I talk. But there is a patient website you can go and look at for this trial, which is called Protector. We want to recruit women who are BRCA carriers to this trial, whether they want to have no surgery at all, whether they want to have the standard surgery to remove the tubes and ovaries, or whether they want to remove their tubes only and then come back for their ovaries at a later date. And I'll go into all that in a minute. But we're very keen to recruit women, whatever your choice is, because without having women in all those three categories in the trial, it's going to be very hard to prove all of the things the trial is looking to prove, which are predominantly actually issues around quality of life. Because it's going to, unfortunately, and this is the big news you're going to want to hear, it's going to unfortunately take many, many years to prove that removing the tubes only is very effective without removing the ovaries straight away. So to go into why this is a concept that is worth investigating in the first place, studies of BRCA carriers who have had their tubes and ovaries removed and looked at sufficiently carefully under the microscope. And incidentally, if you're having your surgery anytime soon, you need to tell your surgeon, make sure the pathologists know I'm a BRCA carrier, and make sure they know to do the correct, what's called the CFIN protocol, which is SEEFIN. And any gynae pathologist worth their salt will have heard of this protocol and will look at the tubes and ovaries using this protocol, which basically means they take multiple slices through the end of your fallopian tube and look at it very, very carefully under the microscope. And that means they are less likely to miss a microscopic cancer or a pre-cancer. And the interesting thing is that in BRCA carriers, and probably the majority of the general population who get the same type of cancer that BRCA carriers get, called high-grade serous ovarian cancer, these cancers start at the end of the fallopian tube. They don't start on the ovary in the vast, vast majority of cases. So the theory goes, if you remove the tubes, then you can prevent the cancers. Now, this is a very good theory, and it is probably true it will prevent the vast majority of cancers, but we can't give you a figure on that level of protection yet. And there are various theoretical reasons as to why it might not offer sufficient protection that you can say it's definitely as safe. Because obviously we would love it if it was as safe, because it could then mean you could avoid a premature menopause potentially. Although as it happens, one of the things that the trial is looking at is how much having the tubes removed might affect your hormonal function. There is every reason to believe it will preserve hormonal function to a large extent. Whether it does so as much as not having the operation at all would do, we don't know yet. And you definitely interfere slightly with the ovarian blood supply when you remove the tubes and leave the ovaries behind, however carefully you do that. But you're not going to interfere with it as much as if you do a hysterectomy and preserve the ovaries. And we know from studies on women who've had hysterectomies with their ovaries preserved that their menopause on average is about 3 to 4 years earlier. So I don't think for a moment, if you have your tubes removed, you're going to bring on your menopause 3 to 4 years earlier, but maybe you'll bring it on 1 or 2 years earlier. We don't know yet. And that's why this trial is so important, to look at, whether you do what you want to do, which is preserve ovarian function for longer. So that's one issue about it. But in terms of the safety of it, well, theoretically, the tubes may be shedding cells onto the surface of the ovary, which look normal. So if you have your tubes removed, they're looked at under the microscope carefully enough, and the pathologist says, yeah, they're fine, there's no sign of any cancer or pre-cancer. It's still theoretically possible that normal-looking cells have already shed onto the surface of the ovary, but those normal-looking cells had already started down the pathway towards cancer, and that they carried on growing on the surface of the ovary and subsequently developed into a cancer, despite the fact that you removed the tubes. The other possibility is that in many women there is an anatomical connection between the end of the tube and the ovaries. And that's sensible. It's designed to keep the fallopian tube in close proximity, near to the ovary. So when the ovary releases an egg, the end of the tube is there waiting to catch it, because that's how you get pregnant after all. So in some, but not all women, there is this sort of connection, loose connection, physical connection, like a bit of elastic, if you like, between the end of the tube and the ovary. And if you divide that bit of elastic close to the ovary, carefully, surgically, you're still likely in some cases to leave a few cells on the surface of the ovary, which actually are part of the tube. So there are these theoretical reasons. The final theoretical reason is, we know from studies in mice, again, mice may not be that relevant to human beings, but there are some parallels at least. Mice, for what it's worth, can develop a cancer of the lining of the pelvis and the abdomen, even if you've removed their tubes and ovaries. So in theory, it could happen. But we don't really know what the likelihood of this happening is as yet. I don't think it's a high risk. If I was a betting man, I would say that removing the tubes only is going to offer you at least 70% protection. My gut feeling is that it's going to be a lot higher than that, but I could be proved wrong. In 10 years, I could be sitting here with egg on my face. So that's why we need this trial. And that's why really you should only have your tubes removed as part of a trial. And then the other thing, of course, is women might not come back to have their ovaries removed at a later date. They may forget about it, or they may just think, oh, I'm going to be fine, and ignore that they may have a residual risk by hanging on to their ovaries. So there are reasons why, there are many reasons why this trial needs to be done. And the other thing, of course, is it does expose you to the risk of a second operation. Now, these operations are not risky for most women. If you've not had previous surgery on the abdomen, and you're not very overweight, then and you're not otherwise unwell, say with severe lung problems or heart problems, then actually surgery is very, very safe surgery. But going through it twice does increase the risks a little bit. And if you've got one operation inside the tummy, that including just having the fallopian tubes removed, You may have a little bit of scarring inside your tummy that can make the operation technically more challenging for the surgeon and therefore may increase the risk a bit. So there are some downsides to having just the tubes removed first, other than the fact it doesn't give you, as far as we know, as yet, the same level of protection.
I think that's really, really useful for everyone to hear, and I've sent through the link to the Protector website on there, but what I'll do, everybody, is I'll send that link through to you all on the email follow-up to this, and you can have a look. But as you said, you know, they actually need people who are doing all the different options to get involved, don't they? So if anyone is interested in helping out, then please do have a click through on that. And we've had a few questions through, that's really interesting questions that we don't normally have, but actually more on the practical side of, you know, how is the operation actually done? Can I trust a robot to do the surgery? You know, is there, you know, any tips that you would have in terms of preparation or recovery and what we can expect actually on the day at the hospital? Is, you know, if you can more practical aspects.
Yeah, sure. So although, as I've already alluded to, it's a pretty simple operation for the majority of patients, I think that getting yourself ready for the operation is absolutely the right thing to do. I think one of the positive things to come out of the COVID pandemic is that people have had to become more health conscious, because it's so obvious that COVID does more damage in people who already have underlying health problems. And that's always been true of surgery. It's always been the case that surgery is more risky and more damaging to patients who have underlying health problems. So if you have any underlying health problems, you need to optimize them as much as they can be. If you're asthmatic, you need to make sure your asthma is properly controlled and see your practice nurse or GP to get that sorted out, because you need a good set of lungs to deal with surgery, particularly with laparoscopic surgery. Please try and lose weight. Crash dieting doesn't work. You need to do this properly and sensibly. I've had a lot of success with patients who've been overweight using the 5-2 diet, or the fast diet as it's also known. But there are many other sensible, medically informed diets, not crazy food exclusion diets, which actually can work in conjunction with increasing exercise. And even a small amount of weight loss can reduce your surgical risks. So don't get downhearted if you've not lost, you know, kilos and kilos and stones. Even losing a kilo or two is going to make a beneficial difference. Keeping active is really important pre and post surgery, once you've got over the initial recovery phase, because it reduces the risk of chest infections, it reduces the risk of blood clots in the legs and lungs, which can be quite dangerous. Not that those risks are high, because your surgical team will do everything they can to prevent those risks from happening. We used to make people starve the night before. We now recognise that that's not necessary and may actually be harmful. So you will be given strict instructions as to when you need to stop taking food, but you can also carry on taking clear fluids, by which I mean water or tea without milk or sugar and coffee without milk or sugar. You can often take those up until 2 hours beforehand. You will get instructions about this from the surgical team looking after you. So these are the kind of practicalities, you know, beforehand. In terms of the day of surgery, bring an overnight bag, because not everyone gets out of hospital the same day with having their tubes and ovaries removed, and it's unlikely that hysterectomy patients will go home the same day, although not impossible. So always bring an overnight bag with you, and then you're going to need someone teed up to take you home afterwards, because I wouldn't recommend public transport. Although you know, a cab, if you live close enough to the hospital and can afford a cab, then clearly that is a reasonable thing to do as well. But it's probably nicer for you psychologically to have a member of your family or a close friend come with you. So in terms of how we do the surgery, not many patients would have tubes and ovaries only removed via a robot, because, to be honest, the surgery is usually too simple to justify the expense of using a robot. I would also argue that most patients with Lynch syndrome, their surgery is equally not so complicated, although it is a bit more complicated having a hysterectomy than having the tubes and ovaries removed. Does require more surgical skill, but most centres wouldn't, by and large, be using a robot for the more standard hysterectomies, although they may do. It will be dependent on your individual centre. The robot's got advantages and disadvantages, but Any experienced laparoscopic surgeon who does a lot of laparoscopic hysterectomies, by and large, isn't going to need a robot. The robot does not do the operation for you. The surgeon controls the robot. Every single thing the robot does is absolutely under the control of the surgeon. So you shouldn't be scared of it from that perspective. You just got to make sure that your surgeon is someone who's properly trained on the robot. And these days, it's very unlikely that that would not be the case. We don't actually use robots at UCH for our risk-reducing surgery because we are all very experienced laparoscopic surgeons. But there is evidence to say that for surgeons who aren't so experienced laparoscopically, or perhaps find it difficult making the transition from standard open surgery to laparoscopic surgery, the robot can make it all a lot easier for them to get really, really good at it. So I think the robot can assist surgeons who aren't inherently gifted at keyhole surgery. It doesn't mean they're not safe to do it. It just means they prefer to use the robot. And that's absolutely fine as long as they can demonstrate that they've got similar levels of safety to surgeons who don't use the robot. I've got no problem with that whatsoever. So in terms of what the keyhole surgery involves, it's under general anaesthetic inevitably because you have to be relaxed enough for them to be able to ventilate your lungs whilst we increase the pressure inside the tummy. We increase the pressure inside the tummy using carbon dioxide gas so that we have enough space to operate around the organs. If we had your tummy all flat and normal without kind of expanding it with the gas, there wouldn't be enough space inside your tummy for us to remove the tubes and ovaries safely without hitting the bowel or the bladder or another part of your anatomy. So we have to temporarily expand your tummy with gas. We let that gas out at the end of the operation, but it can cause a little bit of pain in your shoulder tip afterwards for a day or two before all the gas is reabsorbed, because although we let all the gas out, inevitably some of it gets trapped in pockets, perhaps up under the diaphragm or around your bowel. So we temporarily expand your tummy with gas. We make a 1 centimeter cut, usually in the belly button. Incidentally, if you've had risk-reducing mastectomies involving what's called a Diep flap reconstruction, where the breast surgeon takes part of your tummy wall and swings it up to replace some of your breast tissue, it's important you tell your gynaecological surgeon that you've had that kind of surgery, because in that situation, they will have moved your belly button. It may look like it's in the same place, but it will be in a slightly different position. And on under those circumstances, you should not let anyone put the telescope through your belly button to do the gynae surgery. The reason is that that may compromise the blood supply to your belly button, and your belly button may then die and require plastic surgery to put it right. So because not everyone does as much risk-reducing surgery on brachicarriers as I do, just say to your surgeon, look, you probably know this already. I'm not teaching my grandmother to suck eggs. You know, I apologize if you know this already, but in case you weren't aware, I've had a Diep flap reconstruction, and that means you're not meant to put the telescope through my belly button because it might compromise the blood supply. That's a little aside for very few of you in the audience who might possibly have had that kind of surgery. But for most patients, we make the 1 to 2 centimeter cut within the belly button. We put a telescope through it once your tummy's been inflated with gas. We then put usually 2, sometimes 3 additional smaller holes in your tummy wall. If it was just the tubes and ovaries being removed, usually those would be on either side of your tummy at the level of the belly button, but possibly a bit lower down. Sometimes there's a hole in the midline, so that's as if someone's taken a line and drawn it down your middle. In the pubic area, possibly in the hair-bearing area, and that gives you a little bit of a different angle for manipulation, which some surgeons prefer. But usually there's 2 or at most 3 other small holes, and with a robot usually there's an additional hole as well. So it's not big cuts, and because of that, it's not very painful afterwards, and because of that, you recover from it pretty quickly. But even if you need an open cut in the tummy, it's still not major surgery, and you should be back to normal. With keyhole surgery, you should be back to normal really within 6 weeks maximum, and most patients after a couple of weeks are doing most things as normal, but we do advise you to avoid heavy lifting for more than just 2 weeks. probably about a month or so, I would avoid the heavy lifting and hold off the exercise, gently reintroduce it. The reason is that you can still get a hernia, particularly in the port site that's gone through your belly button, because that's a slightly bigger hole. And it's a slightly higher risk of hernia if you really do push the exercise straight after the surgery. We wouldn't recommend that. With the open surgery, usually that's through a bikini line cut, very similar to a cesarean section cut. If you've had a previous cesarean, which many women have had these days, then the surgeon would normally go through the same incision, or at least cut out the old scar. If it's not a very nice looking scar and you want it to look a bit different, then they can try and make it better for you by cutting out the old scar. So there's never any guarantees it'll look better, I'm afraid, don't blame them. But that's the kind of cut you can expect to get if you have open surgery. It's rarely a midline cut, meaning an up and down cut. With keyhole type bikini, with bikini type line open surgery, you can normally be expected to be pretty normal after 6 weeks, and 100% normal by 6 months. In terms of the physical side of things, if it's an HRT issue, of course, it may not be that that's the case. With a midline cut, the recovery is unfortunately a bit longer, tends to be a bit more painful, and we would really advise definitely no exercise for 6 weeks with a midline cut. But I've seen women get out of hospital within 48 hours of a midline cut, so don't assume you're going to be in a lot of discomfort afterwards. A lot of how you recover is your attitude to how you're going to handle a surgery. And I think the more you can go into it with a positive attitude and say to myself, right, I'm going to get going as soon as I'm told it's safe to get going, and I'm not going to be in significant pain because they've told me I'm not going to be in significant pain. There was a lot of evidence to suggest that if you adopt that attitude and you take your painkillers as advised before the pain gets to a level where you're uncomfortable with it, then actually you won't feel the pain as much as someone who is waiting for the pain to come on before they take their painkillers and who's going into it with a negative attitude of, oh, this is going to be really painful, it's going to hurt like hell. If you go into that with that attitude, your brain is expecting it to hurt more, and guess what? It will feel more pain. There's lots of evidence to suggest this now. So please go into the surgery with the attitude, this is not going to be a big deal. I'm going to get through this physically. I'm going to take painkillers preemptively to prevent me feeling the pain badly in the first place. I'm going to get up and go as soon as I'm told it's safe. And the nurses on the ward will quite rightly be, I won't use the term bullying, I will say they're going to be encouraging you to get up and about as soon as possible afterwards. Because again, there's a lot of evidence that this helps you recover more quickly and safely from the surgery. So they're not being harsh, they're actually doing things for your best interest. It's not that the hospital needs the beds, although they probably do. We really want you to do this because you will recover more quickly if you follow that kind of advice. Now clearly, if you are feeling a lot of pain, it's just possible there's something going wrong with your recovery, and you do need to bring that to people's attention and not ignore it. And the other thing to say, and this is really important, is that with keyhole surgery, because you recover so quickly and we let you go home so quickly, we are of course more reliant on you, the patient, to tell us, the medical team looking after you, that things don't seem to be going right once you're at home. Maybe you're getting increasing levels of pain despite taking painkillers. Maybe you've developed a fever. Maybe you suddenly found it hard to open your bowels or pass urine, or maybe it's suddenly hurting a lot to do either of those things. Maybe you've suddenly got diarrhea when you didn't have it before. You know, if anything seems to be going downhill, don't ignore it. The hospital should have given you a telephone number, maybe to the gynae ward, that you can, or to a clinical nurse specialist, that you can phone to get advice on about these things. And if you can't get through and you really feel things are getting worse, then come back to A&E and just say, this is the phrase I always tell patients to use, I've had keyhole surgery, I'm worried the surgeon's made a hole in something they shouldn't have done. We won't have done, but if you use that kind of language with people in accident and emergency, they have no choice but to take you seriously and to examine you really carefully and order the right kind of tests to make sure they're not missing a post-operative complication. Because the vast majority of post-operative complications are very easy to deal with, and even the more complicated ones are pretty easy to deal with if you do it quickly. The problem and the real risk sets in if there's a delay in the diagnosis of the complication, and a lot of that is down to the patient as well as the medical team. If you don't bring the problem to the attention of the medical team soon enough, and I'm not suggesting you panic at the slightest twinge, I'm just saying be sensible about it. If you really feel, you know what, I was feeling really good, getting better for the last 3 or 4 days, and over the last day or two, I'm feeling really rubbish, something's really changed. If it's like that, please don't ignore it. Please go to A&E if you can't get hold of the surgical team looking after you for proper advice.
That's absolutely brilliant advice. So much good advice here. That's really, really, really useful. I realise we're coming to the end of our time, but wanted to ask a question that somebody sent in just now, is whether you'd ever advise having prophylactic gynae and breast surgery at the same time for BRCA carriers to save them needing to have 2 different sets of recovery.
Yeah. Yeah, very good question, and yes, we've already done that a few times, and there's even been the odd study published on it, and what we know about it so far is that it doesn't seem to cause big problems in terms of, you know, complications, which of course is the first thing that people tend to write up in medical journals. It is technically possible to do in the majority of cases. It will be down to a lot of things, though, as to whether it's feasible. In practical terms, if your breast team and gynae team don't work in the same hospital or aren't used to doing this sort of stuff together already, then logistically it's a real challenge, and it won't be easy to sort out. The other issue, though, which I think is the main thing here, really, is that in all honesty, it's quite a big undertaking to have the breast surgery physically. It may not have the hormone issues, but I think physically it's a bigger issue than the gynae surgery by and large. And clearly psychologically, I mean, obviously every woman is different, but one would assume that psychologically the physical changes that breast surgery causes are bigger than the physical changes that the psychological issues that result from the physical changes that the gynae surgery causes. Hormonal changes, different kettle of fish. So I think for some women, I think the breast surgery is both a physical and a mental challenge. And I think if you added on the gynae surgery, particularly if it was being done premenopausally and you're then facing the HRT issues as well. I'm not saying it's not possible, we have done it, and there are some women who are really positive about doing it like that, and they're resilient enough to deal with it, and that's great. And of course it is psychologically, for those particular women, it may well be beneficial because they're getting it all done and dusted with one episode of surgery and recovery, and then they can move on with their lives a bit more quickly. But it's a pretty big undertaking, and I think you'd have to be pretty confident in yourself physically and psychologically, and in terms of your positive attitude to do that. But yeah, it can be done. It doesn't seem to increase the risk of complications, but it's a bit of a logistical challenge for the surgical teams involved. And for you as an individual, you've got to be, you know, really confident in your abilities to deal with all of that, because it's you know, it's quite a challenging thing to go through. And I take my hats off to all the women who go through risk-reducing surgery, but I doubly take my hats off to anyone that wants to go for it like that. But I would do my best, as with the breast team, to support them in that decision, because the advantages to you as an individual may be great. And, you know, to be honest, it's actually quite advantageous in some ways to the hospital to have one admission rather than 2. But, you know, no one's done the stats yet to say it's financially positive for the hospital as well. Unfortunately, these days we have to take all that kind of stuff into account. But yeah, we would certainly consider it and do our best to support you in that.
Thank you so much for that. I feel like I've learned so much in the last hours, and hopefully everybody watching has as well. Really appreciate you giving us your time today to answer all these questions. And I realise, everybody, that we haven't got through absolutely everything, but I feel we've covered an awful lot of ground there, so that's really, really helpful. I will send around those links that we mentioned in an email afterwards, along with a really quick survey for you to tell us what you think of the sessions and what other sessions you'd like, because we're booking these sessions in based on what you ask for. So you know, if there's a topic that you haven't seen us do and would like us to do, please let us know. So thanks everybody again for coming. Thank you so much, Adam, for giving us your time. Really, really appreciate it, and hopefully see you all again soon.
My pleasure. Thanks very much. Bye-bye.
Thank you. Bye-bye.